Okay, I think we should start.
Yes, time to start.
Okay. Oh, I see Seba. How are you, Seba? Nice to meet you.
Hello, good evening, Dr. Joseph.
Um, you are so misty, Seba.
Yeah, I was a bit away last time, but I'm around now.
Yeah, no worries at all. Uh, so welcome again, everyone. We are going to have a very short but very sweet case that David is going to discuss, and there's a real case that I saw. Uh, so I was waiting for some other investigations to come up, and now I have them. I said, should present this because I find it very interesting. So, David, trust me, at the end it will be an internal medicine case, but the chief complaint this is a 52 female who is presenting with a progressive hearing loss.
Okay, this is interesting, and I should begin by saying, of course, as you alerted before, you said it will turn out to be an internal medicine case. Yeah. So I hear hearing loss. Basically, I do not think I have a very good schema for that one. Yes, but as always, when system one fails, we switch to system two, and basically they don't work exclusively. You can use them together. So I'll try and see where this can take us. So at this point, I should just say maybe if someone comes presenting with hearing loss, what I'll just start broadly to think about. Is this hearing loss that we encounter, are we dealing with conductive hearing loss or sensory neural hearing loss? And by conductive, that means the nerves and everything are very fine, but then we just have a problem with conduction. So, for example, if someone has cerumen impaction, they can present with hearing loss. But otherwise, the nerves and everything else is intact. So that is what we mean by conductive hearing loss. And then the other one is sensory neural hearing loss now, where you have a problem. Now, this is a neurological problem. You have a problem with the neurons. So that's how I can broadly start to think about it. And I think because I'm not an expert exactly, but I think what will help us to differentiate whether this is uh, conductive hearing loss or sensory neural hearing loss, we can have some idea starting with the history and but mostly during physical exam. There are those special tests, the Weber test and Ryan's test. Those are the ones which can help us now to exactly pin it down to one category, whether we are dealing with conductive hearing loss or sensory neural hearing loss. But those are broad categories. So in them, there goes in a lot of things. So maybe let's just hear the history. That will be my thinking for now, and I'll see where the history can take us.
Okay, so this woman can't pinpoint exactly when the hearing loss started, but she reports that over the past several years, she has been noticing difficulty with hearing when people talk to her. It started as minimal and was progressive over years, but currently you have to talk loud for her to hear you. She also reports blurred vision, which she also developed around the same time. She couldn't see properly both near and far objects, and she reported to have changed multiple glasses, which were not so much helpful. She also reported change in her cognitive abilities over years, which are characterized by increased forgetfulness and difficulty with performing simple arithmetics in a business, which she previously performed with her head. She doesn't report ear pain, ear discharge, or tinnitus. She doesn't report eye pain, photophobia, discharge, or eye reddening. She denies headache. autoaugmentation, speech abnormality, focal weakness, numbness or paresthesia, bladder or bowel dysfunction. Okay.
Hello, Joseph. Me either cannot hear.
Uh-huh. Hello. I, I, I think I had a problem with my connection.
Okay, can we start from the same slide, but from the top so we can follow?
Uh-huh. You mean we start with the whole HPI again, or
No, no,
this slide, eh?
the bullet on cognitive abilities, yes.
Yeah, she also reports a change in her cognitive abilities over years, which are characterized by increased forgetfulness and difficulty with performing simple arithmetics in a business, which she previously performed with her head. She denies ear pain, ear discharge, or tinnitus. She denies eye pain, photophobia, discharge, or eye reddening. She denies headache, autoaugmentation, speech abnormality, focal weakness, numbness, paresthesia, bladder or bowel dysfunction. So that's HPI.
Okay, can I see it from the beginning again? Okay, so uh, 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 this is a 45 years old female who has been presenting with hearing loss, which she cannot exactly tell when it's time. Next slide. There is also a change in cognitive abilities. So, fullness. Can I see the next slide? Hello, Joseph.
Hello?
Okay. Yeah. So these symptoms put together, there is hearing loss, there is visual disturbances, and then we also see that there are also some cognitive symptoms. So forgetfulness, uh, difficulties with arithmetics. So and then of course the second bullet is also helpful, that there is no ear pain, no discharge, no tinnitus. As I said earlier, hearing loss can be broadly categorized as conductive as well as sensory neural hearing loss. Anything is still a possibility here, but if we put these symptoms together, hearing loss, visual disturbance, as well as the cognitive changes that we see, I would put my bet on that. Probably the hearing loss that we are dealing with is mostly sensory neural hearing loss rather than conductive hearing loss. But as I said, medicine never ceases to surprise us. So it can also be conductive hearing loss. But from this point on, I think I'll try and think. Probably what we are dealing with is more neurologic rather than something conductive, especially with the hearing loss. Now, what exactly is going on here? Yeah, I think this is a very good exercise to recall neurology. So there is a hearing loss, and then visual disturbances, and then cognitive decline also. So what exactly is going on? So with hearing loss, if we are talking about sensory neural hearing loss, I mean, it can be anything. Maybe because when we talk of hearing, we are talking about the vestibulocochlear nerve, and right now, mostly now we are talking about the cochlear branch of the vestibulocochlear nerve. So something with the nerve. I mean, you can have something when you talk of sensory neural hearing loss, like a tumor of the nerve, for example, a schwannoma or something of that sort. But then, so it could be in the nerve. I mean, if we consider the hearing loss by itself, it could be a problem in the nerve, but again, it could be a problem in the brain. And the way it seems now, so it could be that we are dealing with, I mean, these are three problems that we are dealing with: hearing loss, visual disturbance, and cognitive decline. Uh, they could be three separate problems, but I wouldn't start thinking that way. I would try very hard to see if I can find a point of convergence, something that explains them under one umbrella, before I start looking for separate pathologies that can explain these three things separately. So if I try to think of it in terms of uh, under one umbrella, then I would think that the problem is in the central nervous system, most likely in the brain. And where exactly in the brain? Because if you talk about processing of hearing, you'll definitely talk about the temporal lobe, but the frontal lobes are also involved in a way. When we talk about vision, a problem can start right from I mean, you can have a refractive error, but it doesn't seem to be a refractive error. This patient cannot see near as well as far. It can be a problem in the retina. It can be a problem with the optic nerve, which is a possibility. The optic nerve is part of the central nervous system. So, for example, if this person is having papilledema, or if it's not papilledema, you can have optic disc atrophy, which can happen with a number of pathologies that could explain the visual disturbances. But then it could be a problem in the primary visual cortex, which is the occipital cortex, or some supplementary areas, which can have an association with hearing also. And then when we talk of cognitive abilities, I tend to think more of a frontal lobe problem, a frontal as well as the parietal lobes. So what exactly is going on now? One pathology that can explain these things. The presentation, the patient cannot exactly remember when it started, but I can think of a number of things. So, for example, we haven't heard anything about movement abnormalities or any other thing, like a tremor, which could point us in the direction of a Parkinsonism. But there is a number of atypical Parkinsonisms, or I shouldn't talk about Parkinsonism because we don't have a tremor or rigidity. We haven't heard of anything yet, but I should try and think about the dementias. So there are some forms of dementia that can present with the cognitive decline that we see, but then of course difficult to talk about the visual disturbance as well as hearing. But yes, a number of them I'll try and think very hard. For example, um, temporal lobe degeneration. Yes, we have a group of disorders which are characterized by temporal lobe degeneration. Now I cannot, I cannot, maybe I won't be very precise in mentioning all the subtypes, but we have some tauopathies. So you have a deposition of these abnormal proteins or tau proteins where you have misfolding. So those tauopathies can present this way. So you have cognitive decline, but also some of those subtypes which I cannot remember correctly, but they fall under this broad category of temporal lobe degeneration. So those ones can explain such a presentation. So that is one of the things that I'm considering in this patient. But then, apart from that, something else that can that can explain all these things at the same time is something like mitochondriocytopathies. So you have a problem with the mitochondria, which is the powerhouse of the cells. So you can have a presentation like this one: visual disturbances, hearing loss, dementia. But then mitochondrial cytopathies do present with metabolic abnormalities. For example, some do present with metabolic issues like diabetes. But then, so for many also see motor symptoms, like people present with features which are consistent with myopathies, which we do not see in these patients. So I should say a very difficult case, but up to this point, I'm considering those few things. We are probably dealing with some sort of dementia that includes visual as well as hearing disturbances like the ones that I mentioned, but also mitochondrial cytopathies. I'll try and think if I can have other differentials, but other components of the history, especially the family social history, I'll concentrate on that, the past medical history, but then physical exam, maybe it can help me make some progress. So more history.
Um, yeah, that was the very nice discussion. So let's proceed. Review of her system was unremarkable. Past medical history: she has diabetes, which was diagnosed in her mid 30s, which was poorly responding to oral hypoglycemic initially and so transited to insulin. And there is one problem that made her present to my clinic. She requires very large doses. So when I saw her, she was like on 1.5 international unit per kg per day, and still the diabetes was uncontrolled. There is no previous surgeries. So the meds right now, she's on insulin, intermediate and short acting, and atorvastatins. Family and social history. So her mother passed away in her mid 50s, the cause being the complications of diabetes. Her mother had also diabetes and hearing loss. She has a younger sister who is in her mid 40s, who also has diabetes and hearing loss. Her brother has diabetes, but the brother doesn't report problems with hearing. And she has other siblings and their father who are all healthy. She has one daughter who is healthy. She works as an entrepreneur, and she doesn't drink, and she's a lifelong non-smoker.
Okay, thank you, Joseph. Of course, it's a difficult case, and I should say I think after this I'll have to go and read more. But as I said, I was very much interested in hearing the past medical history of this patient and the family social history, which turned out to be revealing. So this patient has a mother who was diabetic and also had hearing loss, and then a sister who had the same, and then there is a brother who has diabetes but no hearing loss. And this patient was diagnosed with diabetes early on. So um, I should say my knowledge is very limited here, but at this point, I'm very much convinced that to throw away the dementias, the tauopathies, and everything else I was talking about, and focus more on these mitochondrial cytopathies because of this family history. So there's a family history of diabetes and hearing loss. And I remember solving one case. I believe, Joseph, you've done the same because you do a lot of these cases on the New England Journal of Medicine, on the New England Journal of Medicine. There was this one case, I think it was a while back, but almost the same. But was that a male or a female? But then the same thing, presenting with hearing loss, diabetes, and then there is a strong family history of diabetes as well as hearing loss. So I should say that is the only thing that. So when I heard about hearing loss and then cognitive decline and everything else, my mind flashed back to that case, and then the family social history seems to be pointing me in that direction. But I do not have many details on that, so I cannot even remember the exact names. So Joseph is going to tell us later. But at this point, by pattern recognition, I should say probably that's what I'm inclined more to think that it is what is happening with this patient. So it's something genetic, it's something hereditary, and that's something hereditary. You are talking more likely the machinery of the cells is having a problem. That's why we see a very strong family history of diabetes as well as hearing loss. But now, exactly what exact phenotypes are we talking about? What exact phenotypes? I cannot. I should be honest. I do not exactly remember the names. They have some fancy names. I'll see if I can recall any as we are going on. But at this point in time, I'm thinking that is what is happening. That you have a hereditary problem, uh, and yeah, I mean a genetic problem which is passed down. There is a positive family history in the mother as well as siblings. Now, is it a sex-linked problem? Because we see that there is one male sibling who does not have it, but then all the female siblings and the mother have a similar problem. What exactly is happening? If you talk about something which is X-linked, males are more prone to getting that as compared to females, because females have two X chromosomes while males have only one. The other one is the Y chromosome, which in some setting doesn't seem to be as useful as the X chromosome. So uh, I wouldn't uh, I wouldn't be convinced that it's probably a sex-linked issue, but maybe there is some protective factor in the brother, or it's just part of the natural history. He already has diabetes, and maybe the hearing loss will come later. But yeah, I cannot put a name to it at this point, but I'm thinking that's what we are dealing with. Most likely a mitochondrial cytopathy. But what exact phenotype, not exactly sure. But let's see as we get to the physical examination and investigations, if I can change my mind. But at this point, that's the only thing I can think of because of my ignorance.
Okay, that's a lot of information. There is no ignorance there. Okay, so we move on. The general exam was unremarkable. Everything was okay. Systemic exam. So neuro exam, higher centers was normal. The cranial exam was only, there was only a finding in the cranial number 8. There was reducing hearing bilaterally. But other cranial nerves were normal. Motor and coordination were normal. Sensory exam was intact. Abdomen, respiratory system, cardiovascular system were all unremarkable. Do you want to discuss the exam?
Okay, so nothing very surprising in the physical exam. Uh, I think at this point, with all we've seen in the history, hearing loss, visual disturbance, and then cognitive decline, uh, I think yes, it was prudent to skip on on determining if the hearing loss that we are dealing with is conductive or sensory neuro. We are thinking most likely it's sensory neuro, so maybe the verb as well as Ryan's test were yes, could be skipped in this patient. But because of the visual disturbance, maybe, and yes, I I share the same concern that probably in the outpatient setting it could be difficult to do a detailed fundoscopy. But I think because the patient presented with visual disturbances, maybe if a fundoscopy was done, we could find something like optic disc atrophy, probably, or maybe the visual disturbance that we see is deep in the brain. So maybe the fundoscopy would be non-revealing. So yes, the hearing loss that we see most likely sensorineural, other cranial nerves are intact. So the issue comes, I said, some mitochondrial cytopathies do present with motor symptoms. So features of myopathy, which we do not see in this patient. I believe not all should present with motor abnormalities. So I think the physical exam is not very surprising. It doesn't help making more progress though from what we had in the history as well as in the HPA as well as other components of the history. So let's see where the labs and other investigations that you have can take us.
Yeah, that's a very nice observation. So, in terms of visual exam, I didn't have the things, but she had done it, and the ophthalmologist had told her what she has in her eyes are complications of diabetes. We'll see later about the proper sensory neural hearing loss exam. And so we move on. Here are the labs. HbA1c was 9%. Fasting blood glucose was 16. Fuba picture was within normal limit. She did some chemistry, which were all within normal limit. Urinalysis showed the plus 3 proteinuria. So she also had an ENT review and audiometry, which the result came back that she has bilateral sensory neural hearing loss as the conclusion. Yeah.
Okay, so from these labs, what we see is her diabetes is uncontrolled. Diabetes is uncontrolled with the glycated hemoglobin of 9. Our target, someone who is diabetic, we expect, so we can say we've achieved the glycemic control to have a glycated hemoglobin below 7. Oh, yes, because she's 45, no other comorbidities, so definitely would try and be very aggressive in treating the diabetes. So our target is a glycated hemoglobin below 7, but it's 9 despite the increasing insulin doses she's been having. So the diabetes seems to be uncontrolled with fasting blood glucose of 16, very high. And then urinalysis, I think we're already starting to see the complications of the diabetes in the kidney. This patient is having diabetic nephropathy with proteinuria. So I think one issue about controlling this diabetes is so this is a genetic kind of diabetes that we are talking about. I'm not exactly sure. Yes, I mean they fall. It can fall, can or cannot. Joseph will tell us later. But so when we talk of diabetes, we have those categories: type 1 diabetes, type 2 diabetes. Now this one doesn't fall in any of those. So this is a monogenic form. I'm not sure if I can call that one, but yes, a monogenic form of diabetes. So with a hereditary form of diabetes due to other issues, you are not talking about autoimmune disease in the pancreas. You are not talking about metabolic syndrome. You are talking about some other problems. And yes, these kinds of diabetes are very difficult to control. So I think that is what we see there. So audiometry, again, sensory neural hearing loss, as we said earlier, most likely because of the other presentation, we're thinking more it's more sensory neural rather than conductive hearing loss. So yes, I think now what else was, I'm not sure, Joseph, if you have any other investigation. So this is where we commit.
I have the last one.
Hello, Joseph.
Yeah, I have the last investigation. Just one.
Okay. Okay, let's see that.
what do you think that is?
Okay. Okay, well, so for a case like this one, uh, what we so definitely what we need to have at this point is the studies that we need now are genetic studies. They are more of genetic studies in order to determine what exactly is going on now, because I couldn't even tell the exact phenotypes. I remember reading about them, but then too bad for me, I didn't go and read in details. So I cannot even remember the exact phenotypes. So which exact genetic studies we need to do, I cannot tell, but definitely I would need some genetic studies, karyotyping, in order to see what exactly is going on.
Okay, genetic studies are hard to find. We decided to send a GAD65, which came back negative. Would you comment anything on this?
Okay, so I cannot remember the long form, but then GAD65 is one of the markers that we use in telling if the kind of diabetes we are talking about is autoimmune or not. So those are some autoantibodies, against islet cells, if I remember correctly. So that being negative, of course, you are ruling out uh, type 1 diabetes. There are some others. I cannot say confidently that you rule it out completely, but then GAD65, I believe, is one of them. And then we also have insulin antigen, antibodies against insulin antigen, a number of them. So I think to some extent we are ruling out autoimmune forms of diabetes, and therefore, with the strong family history, we are more inclined to think about the monogenic forms of diabetes. And with the presentation that we see, I think mitochondrial issues. Yes, you can teach me more on that later.
Okay, so what's the diagnosis here?
Yes, so I do not have many differentials at this point. Uh, my diagnosis in this patient is we are dealing with a monogenic form of diabetes. Of course, diabetes is just one component of a bigger problem, which is a hereditary problem. And I'm thinking more about okay, so there's this form. Can I let me try and see? So it's diabetes and sensorineural hearing loss. Maternally, is it called the maternally inherited diabetes and hearing loss? There's this short form. I've tried very hard to recall, but I can't. So I think we are dealing with the hereditary issue, most likely a mitochondrial abnormality, or if not a mitochondrial abnormality, some other thing, but then most likely has to do with the mitochondria, which is hereditary. That's why we see a strong family history. But then the exact phenotype will tell us.
Okay, so I can say I'm impressed, and yeah, that's the journey that I also went. So it turns out your story and my story are the same, coming up to the diagnosis of this patient. So this patient showed up in the clinic with the problem was uncontrolled diabetes. She was using very high dose of insulin, and at that time she had the GAD65. She told me about hearing loss and visual stuff. So my thing was to, yeah, to play with the insulin, but so we were communicating, and I would say, well, add this insulin, and then I think I read the case that you read in the New England, and then I'd say, okay, this woman had diabetes, and the difference is I called her and I asked, and she told me about her mother and the sister and the brother, and I said, this is the thing. Even if we cannot perform genetic studies here, uh, this is we should suspect this thing, and it is important, as I will show you later. So I can say I'm very, very impressed, David. Keep up. So let's go and see some learning points. I First of all, let's see. We learned from you a lot of things you were saying. So really, we are not ENT, but at least we are internal medicine. We are very broad, as everyone saw today. David is doing is discussing hearing loss. Not much conductive sensory neuro. Very true. And because there were other neurological stuff, David decided very early that this is going to be sensory neuro, which turned out to be true. And you localize the problem of the sensory neural hearing loss either in the vestibulocochlear nerve or in the brain itself. And so another thing that you said, if it is in the brain, it should be in the temporal parietal region. Also the visual, you say the problem with the visual can be localized in the retina of the optic nerve or in the primary visual cortex on the supplementary areas. This is very nice. I learned from you. And cognition is in the brain, the frontal parietal areas. Based on this forgetfulness and stuff, you initially thought it can be degenerative disease, but you queried there are no other features like motor symptoms. And very early, you thought this can be a mitochondrial stuff, which turned out at the end it is. You inquired whether there is diabetes in the family history. You reminded us of the types of diabetes: type 1, type 2, and monogenic diabetes. And the truly you mentioned other autoantibodies that are involved in diabetes type 1 and other types of diabetes. Other than GAD65, there is also ICA. She didn't do ICA, but she did GAD65 and the insulin antibodies. And lastly, you came up with the correct diagnosis. I love that. So my learning points is, first of all, the classification of DM as type 1, type 2 is so old. We should get away with that. So DM can be classified as type 1, type 2, LADA, monogenic syndrome that David was saying, and others. So type 1 diabetes is 60% of all patients with diabetes. 80% of these patients are diagnosed before age 20, sorry. And they have positive antibodies. You're talking about GAD65 and ICA mainly. If you do these two, you're done. But you can do others. It will be very costly. And both of these are available in our country. It is done. So these patients with type 1 diabetes can present with DKA diagnosis, but not necessarily. And they usually have one thing: they have a rapid progression to need insulin. You diagnose them today with DKA, they just need insulin from there. Type 2 diabetes, the one that we see every day in our clinics. 90% of patients you see with diabetes, they have type 2 diabetes. They're usually of older age and they have negative antibodies. So this patient had negative antibodies. Would you classify her as type 2 diabetes? Not really. She was in her mid 30s when she was diagnosed. But when I saw her, that is how she was being classified as having a type 2 diabetes. But there are also another called LADA, latent autoimmune diabetes of adults. There's a controversy around this. Some people say it is just a type of type 1 diabetes, but not in the young population, in the adults. So in this, the antibodies are usually positive, but these guys are not young. They can be above 25. Most that I have seen with LADA, they are around 30 something. And they will slowly progress to need insulin. You start with their orals, and after like 6 months, 1 year, they'll need insulin. So this patient didn't have LADA because at least the GAD was negative, and it couldn't explain other family history. And then at lastly, you have the genetic diabetic syndromes. You're talking about things like MODY here, maturity onset diabetes of the young, or neonatal diabetes, or as a diagnosis in this case, the maternally inherited diabetes and deafness. But we have other types now. Think of exocrine pancreatic insufficiencies with patients with chronic pancreatitis. They have diabetes. What do you put it? You put it in others. Or patients with trauma in the pancreas, and at the end of the day, they have diabetes. So if we go to MIDD, this is a syndromic disorder which is caused by mitochondrial mutation. The mutation is called M3243AG. I don't know what that means. The epidemiology thought that globally, 1% of population have this syndrome, and 0.5 to 2.8% of patients with diabetes have this disease, but they are incorrectly diagnosed as type 2 diabetes, which is not. So take your time, ask about hearing loss in patients with diabetes and family history, and you can tell something. And it's important, as I will show you later in the management. So the age of diagnosis is usually around the third or fourth decade. The mean age is 37 years. This patient is mid 30s. Her sister mid 30s. Even her mother mid 30s. The pathophysiology involved here is that there is altered ATP generation in pancreatic B cells, leading to decreased insulin secretion and the B cell apoptosis. And the presentation include sensory neural hearing loss, macular or retinal lesions. So I wish I would go back to the ophthalmologist and ask properly. Maybe this patient has macular lesions and not that's the complication of diabetes. Maybe it's not the complication of diabetes that we see, but the peculiar presentation of macular or retinal lesions that are different from retinal complications of diabetes. They also have neuropsychiatric complications. This patient have they can have myopathy, they can have renal diseases like renal failure, proteinuria, as we saw. They can have cardiac presentations like maybe dilated cardiomyopathy and others. So you should suspect this disease when you see a family history of diabetes with hearing loss, visual disturbance, renal disease, and if you send labs, rule out LADA by sending GAD65 and ICA. But at the end of the day, you need genetic testing. We couldn't get this. So treatment is individualized. Every patient will respond different. Like this patient was having insulin resistance. So we used lots of insulin dose. It is thought that if you give this patient coenzyme Q10, which improves mitochondrial function, they improve the symptoms, but it doesn't alter the progression of the disease. Only gene therapy can be curative, but still in the trial, it's not used to treat patient. So for important, this patient should avoid some drugs that will further damage the mitochondria. We talk about antibiotics like tetracyclines, chloramphenicol. We talk about antipeptic drugs like valproate and phenytoin. We talk about antiretrovirus drugs. Metformin, imagine this patient was on metformin initially, and as I would do if I diagnose the patient, I will start on metformin, that's the best drug. But they shouldn't be in this drug. And statins, this patient was statins. So I after I knew this, I told her maybe she should come off the metformin, the statins, as the disease will progress faster. Lastly, not much. David, from you, did a very great job today, my friend.
Thank you very much, Joseph. So first of all, I should say, I think one of the things that we clinicians, one temptation that we should try very much to avoid is chasing zebras. So zebras are those oisoteria. Another term is zebras are those very rare diagnoses. So this definitely is one of those very rare diagnoses. I mean, as you can see, among all patients with diabetes, it's a very tiny fraction that have it. But then when someone has symptoms or a clinical presentation that is in keeping with a particular diagnosis, we shouldn't resist to think about it just because it's rare. So something being rare does not mean it doesn't happen in a patient when they have a consistent clinical syndrome. So I should say I do not have much to say, but I think one thing I've learned is that I think just random reading, sometimes you come across something, you read, and maybe you think you may never come across it. It's not wasted time. Sometimes, I mean, it can be helpful in the future. So, for example, Joseph, if you hadn't solved that case in the New England Journal of Medicine, maybe you wouldn't have thought about this diagnosis. So sometimes I think it's a relief for patients, even if there is no management for the particular disease they are suffering from, but it's they get some relief at least knowing what is wrong with them, rather than wasting resources on keeping testing and maybe trying some other treatments which wouldn't work. So I think getting a correct diagnosis is doing a very big service to the patients. So before I start cheering for getting a rare diagnosis right, I think I should congratulate you for helping this patient, because at least they are now aware what is going on with them, so they know what and what not to do. So you did a very good job and a very great service to this patient. So I think after this, I'm just convinced that I should keep reading. I should keep reading, even if sometimes you come across cases that you think, okay, this won't be much of help in our setting because I think it's something very rare. But then just reading around, sometimes it can save a patient. So yeah, a little happy for getting a rare diagnosis. But I think I'm more impressed with you that you were able to make the diagnosis and you helped this patient. So thank you very much.
Thank you. Lots of wisdom there. We still have time. So if we have anyone from the floor speaking on anything that you feel speaking, you can congratulate David for getting this diagnosis. No one?
Hello, Joseph.
Hello, Kazaura. Karibu.
How are you, my friend?
I'm very good. How about you?
Yeah, thank you for a very nice and enlightening presentation. It is very unfortunate that the patient's disease is incurable. But I think to help the patient, maybe we could have traced those modalities of gene therapies if we want to get that services, how much, which country you can maybe get that treatment. I think they deserve more than the diagnosis. It is very true that, as David said, the disclosure of a true diagnosis might also help the patient somehow. But I think we also need to try to go beyond our limited resources. I think we again need to focus, try to search different the cost where this patient can get the treatment.
No.
Maybe some of them can afford. You never know, because diabetes in young is a bit lifelong burden. It's a very good case to learn, and I think, as David said, the more you read, the more you get knowledge.
Yeah.
Thank you.
Thank you very much, Kazaura, for taking an interest and thinking about how we can help this patient. So the gene therapy, I read it was a review paper of 2024. Yes, 2024. So very recent. It said it is in trial, but it is not yet put into practice. So still, what we can do, if you can get the CoQ10 and avoid some medications, to reduce the progression, but at the end of the day, the disease will progress.
Okay.
Okay, karibu. Anyone else? Okay. So, David, any last words before very close?
Yeah. So I like to thank everyone for joining us today. I see the crowd is not very huge, and a closely knit crowd, same faces, same names. So this tells us how much interested you are in learning. So we are very happy to see you, the same people that we see almost every day. So I believe this is having an impact on the service that we offer in our patients. So learning every day, continue improvement. I think that's doing a great service to our patients. So thank you very much, everyone, for joining us. We look forward to having you back next weekend. So we'll share the link. Feel free, everyone, to share the links to other people in your circles, so we can have a bigger crowd joining us, so we can keep sharing knowledge. So otherwise, good night, everyone.
Good night, everyone.
Night.